To the extent that we live our lives in a manner that is consistent with the truth in our heart, we thrive.
Welcome to the Meier Clinics podcast, and you just heard a quote from one of your hosts, Dr. Lisa Day. Join our licensed clinical professionals from various backgrounds as they discuss fascinating mental health topics with a wide range of guests. Meier Clinics is a Christian counseling organization with multiple clinics nationwide dedicated to treating the whole person, emotionally, physically, and spiritually. Welcome to our listening family. We thank you for joining us. Hi, everyone. Kristen Walker here, your host, here with Dr. Paul Meier. Hi, Paul. How are you?
I'm doing fantastic.
Great. And also, Dr.
How are you guys?
We're good. And Lisa, Dr. Lisa Day, you're here with us too. How are you,
Yes,
Lisa?
I'm doing fantastic. Thank you so much.
So today, Paul's going to start us out. Dr. Meier, I'll refer to him as Paul, talking about something that is near and dear certainly to my experience and my heart because of a family with a lot of mental illness, which we don't like to necessarily use that term since it's so stigmatized, but it's not any different than heart illness or, physical illness. It's really okay to use that term. So we're going to have Paul start us out with what we're going to discuss today.
Okay. Today we're going to have a roundtable discussion here with the three of us on treatment-resistant mood disorders, but that includes anxiety, depression, and all the things that I, as a psychiatrist, would see, or Lisa, as a therapist, would see. And out there in the, if you Google stuff like that, it seems like there's a lot of people that are treatment-resistant, and what that means is no matter what people do, they don't seem to get better. And my opinion is that most people who are treatment resistant are not getting the right kind of therapy, or there are some reasons why it takes longer for them to get therapy, or if they do need medications, they may be getting them from a family doctor that's giving them the low dose of the wrong medication because he's not a trained psychiatrist. Or even psychiatrists can make mistakes if they don't have enough training, like if somebody has a first-degree relative that's bipolar, for example, but you don't have bipolar, the antidepressant won't work on you unless you take a mood stabilizer with it, then it'll work great. So, half the psychiatrists in the country don't even know that. And so they would try one antidepressant after another, and none of them would work. And they'd call that patient treatment resistant when it's just a lack of knowledge. And so there are some people that are treatment resistant that really try, and they have really good therapists and really good psychiatrists that occasionally will nothing seems to work even after 9 months of trials, and even those usually somebody really there's this Jewish doctor in town where if I get stuck on somebody about once every 6 months, I send them to this really smart Jewish doctor in town, and he can always figure out something, and if not, he occasionally he could use ECT, and that would almost always work. So it's almost treatment resistance exists, but it's a lot more rare than what you'd think about from the literature. So sometimes it's hard. Most of the time it's easy, but that's sort of what we're going to talk about. So we're going to bring up a whole lot of different topics relating to that and discuss them.
Great. So Dr. Day, I know you have, Lisa, you have questions around this that you wanted to ask Paul. So let's start with a few of those, and then we'll flip it back to you and ask you some questions that things that you've noticed in your practice.
Sure. Before I launch into the questions, though, I just wanted to state a few things that I experience in my practice and that we know to be true. And the reason I've wanted to address treatment resistance is because I believe that people get discouraged, far too quickly. And I think that for mainstream society, we forget that, according to NAMI, 1 in 5 people, are struggling with mental illness, and only 50% of people struggling with major depression are even getting treatment. And, we've had so many suicides, we've got the star suicides of Robin Williams, Kate Spade, and Anthony Bourdain, but we've got 45,000 people a year who are killing themselves. And what I do and what I see, in my practice is that folks with chronic depression, for instance, are 6 times more likely to kill themselves. So the concept of treatment resistance is one that shows up in my practice. People will come and they say, I'm not going to take medications. I've tried them. They don't do anything. They don't work. They make me feel worse. I flatline. I can't think. And, one of the things that I do as a psychiatric nurse and clinical psychologist is try to educate them, educate folks on what the process of going through, finding the right medication. And, there's lots of contributing factors. And Paul, I know that you probably see all of these. And, but what I find even before my folks get to a psychiatrist is that there's still a significant amount of stigma attached to mental illness. And I find, and I don't know if you see this, Paul, that many clients don't want to go to a psychiatrist and get on, say, Prozac or Effexor or, Paxil, because that would then mean that they have mental illness. And so they struggle even moving to get on medications, much less find themselves treatment resistant. So I know that, stigma is something that I see. But the next thing that I see is people, are easily discouraged and quickly discouraged. And so, one of the questions that I have, where I would start is, what is an average trial, if you will, on a first medication that you would encourage a client to be on before you would want to switch or change the dose? How does that start out? What does that look like in your practice?
Okay, those are really 3 good questions. The stigma, when I first went into psychiatry back in 1975, they're almost, the word Christian psychology, barely existed. And back then, psychiatrists basically thought all Christians were crazy. And, I'm being a little bit dramatic, but most psychiatrists, 25% of Freudian analysts said that their treatment of a patient wasn't complete if they still believed in God, because they were using a rubber crutch. And, and Christians thought all psychiatrists were crazy, which a lot of them are, the first time I went to a residency party, it was an outdoor party, and my wife and I were walking across the football field to get to where they were, and some had their shoes off and were picking their toes, and some had beards that you could hardly see their face and stuff, and she said, "You didn't tell me it was a costume party," because from the distance that's what it looked like. I said, "No, that's the way they always look," but most psychiatrists are okay, but you can see why. Yeah, Christians would be afraid to go to a psychiatrist, and psychiatrists would have a negative view of Christians. But over the years, so I had a really good buddy in residency, and we were prayer partners, Dr. David Larson. So we dedicated our lives to helping that, and he dedicated his life to helping psychiatrists accept Christians, and I dedicated my life to helping Christians accept good, healthy psychiatry that's not anti-biblical. So I ended up writing 100 books that sold 8 million copies in 30 languages, and doing radio to 2 million people a day for 25 years daily. And he ended up working on research that shows that people who are Christians are actually healthier than non-Christians and have less depression and less anxiety. And half the medical schools in the country now have a course that he designed. And he died about 15 years ago of a heart attack, and they gave him a chair in the Library of Congress next to Kissinger's chair, honoring him for his research in the value of religious beliefs. It didn't name any one religion either. I mean, but it showed that people with religious beliefs, it can be a strong thing, and not that doctors need to not put that down. So the stigma is a lot less now. Most, I think the vast majority of Christians don't mind that much going to see a psychiatrist, but maybe 20% still do, and most psychiatrists are taught to not make fun of people's religious beliefs, and so now there's a lot more interaction. But the stigma is still there, like you said, and for a lot of people, and so a lot of people that have depression will say, well, I have chronic fatigue syndrome, which does exist, but 9 out of 10 people that think they have it don't, or I have this or that or the other thing, and they'd rather have it be a medical illness and things like that. So the stigma, what I try to do when people do come see me for the first time is I explain to them that some people inherit a low thyroid level, so they have hypothyroidism. Some people inherit a low insulin level, so they have diabetes. And if they don't take insulin, they're going to die. And if they don't take thyroid medicine, they're going to die. And I say, there's about 4 main chemicals that keep us healthy and happy and sane and all that. And one of them could be genetically low, just like anything else. And so if you take a medication, it doesn't make you, like an antidepressant doesn't make anybody falsely happy. It just helps you to hang on to the serotonin that you're getting from the food, so that you're when you're on an antidepressant and you're happy, that's the normal you. And sometimes I even share with them that I take that I see my own shrink and I take my own meds for my genetic things. I've got ADD and one or two other things, and I said I'm going to try you on the medicine that I take. And that helps take away the stigma. And then you mentioned getting discouraged and pessimistic. Anyone that's got a low serotonin level, for example, there's thousands of people listening to us right now, and we appreciate you being here with us. You're our listening family. We love you and we care about you. That's why we're doing this. Mm-hmm. And if all of us, if the thousands of people right now, plus the three of us, all got an injection that lowered our serotonin level, we'd all either be suicidal or we'd be so discouraged that we'd feel like that the depression's never going to go away, no matter what anybody does. So you automatically, when it's low, you automatically get real pessimistic and feel like it's never going away. And my clients that come here for the first time say, I don't know why I'm even here. I know nothing's going to work. And, maybe they tried one thing where they had bad luck on it. And then the third question was, and I'm going to try to answer these short because I know there's a lot of questions. But you asked, Lisa, but what's the average trial? Well, if somebody's had panic attacks for 30 years, we can get rid of them in 15 minutes by using medications, and they'll never have another one the rest of their lives. If we give them enough medicine to hold them over until the ones that are really good to take, that take a month, can build up, then we can drop the ones that work right away that are maybe not as good to take long term. And most people, we see about 1,000 people a day at the Meier Clinics nationwide, about half of them for depression and half for all the other reasons. And about 75% or 80% just get counseling and don't need medications. And so some people are afraid even to get counseling because of the stigma, or they might have seen a counselor. About half the therapists in the country are Rogerian therapists. And if you're Rogerian, you don't give any advice to anybody. You're supposed to not even talk to them. I got chewed out. I got my training at Duke, and we got training in all different fields of therapy. And my Rogerian therapy prof got mad at me. I didn't say a word to the patients when they came in. It was a miracle couple. I said, well, talk to each other and share with each other, and we'll see where it goes. And but he got mad at me because I told him where to sit. I said, go ahead and have a seat right here. And he said, you shouldn't tell them where to sit, And so, you just sit there and you grunt, and of course they're not going to get any better. A third get better, a third get worse, a third stay the same. And if they don't ever see a therapist, it's about the same proportion. And so they may have had a counselor that wasn't that good, or there might be reasons why they're resistant to listening to the counselor. So there's the average trial, by the way, for depression is a month. So somebody's significantly depressed, and again, we use medications if somebody has a genetic disorder where they need lifelong medications because they inherited a low level, and we use them for people that don't have a genetic disorder if they're so depressed or so anxious that they can't go to work or can't go to school, and it's interfering with their lives. We can give them medication for maybe 6 months to a year, and then they can get back off it once they've had therapy to resolve the conflicts and do well without it. But now if somebody has depression, then we give them an antidepressant, and depending on the type of depression and other factors, and each antidepressant works about 75% of the time. It's not like the anxiety medicines work 100% of the time, but each one works about 75% of the time, and it takes a month to have a full effect, 4 to 5 weeks. So I put them on one and have them come back a month later, and if they feel quite a bit better but not great, that's wonderful. Then I increase the dose, and 2 weeks later they feel great. If they don't feel any better after a month, then I'll switch to a different antidepressant. And so the average trial for that is a month. Now, I saw a patient today who went psychotic, and so he went psychotic on Wednesday night, and he was delusional and things like that. And so I started him on major tranquilizer, and I told his family, I said, he'll be normal within 8 days. So if somebody thinks they're Jesus and hears voices and has all that sort of thing going on, we can put them on a major tranquilizer at a high dose where they're a little bit zonked for a few days. And 8 days later, they'll be normal and look back and say, man, I can't believe I was believing all that junk. And so, you know,
Yeah.
it's just modern medications are amazing. So that's as short of an answer as I can give you to those two questions.
I have a clinic
Sorry.
situation. I have a clinic situation in mind, and a young woman who I've worked with for many years. And, you know, if we look at treatment resistance and frustration and a challenge, and it's really when there's comorbid or more than one diagnosis occurring at one time. And this young woman, you know, early on presented with ADHD. As she grew a little bit older, got into her early teens, she began to present generalized anxiety, social anxiety. And then when she moved on to her later teens, you know, she developed presented what really looked like bipolar disorder. And one of the interesting things in the journey with her, both again as her therapist, but also as a psychiatric nurse, really working intimately close with she and her prescribing physician, was to watch how the change in the particular need and class of medication occurred for her, and really being open to that. Meaning early on, you know, she was put on the Concerta, the Ritalin, I think they tried Adderall, and all of them were really effective for the ADHD. But then when she began to develop generalized anxiety and social anxiety, the toss-up was, are the stimulants causing this, or is this a separate, you know, comorbid diagnoses? And, you know, years of battling, do we take the stimulants down? Does her doctor put an anti-anxiety on board? And, you know, navigating through that, discouraged, she came off all of her ADD medicine, came off all the anti-anxiety medicines, went for a period of time and really crashed. I mean, this young woman was hospitalized about 6 times before, again, you know, dissecting and getting into that symptom presentation, she was landed with the diagnosis of bipolar. And she went right from, you know, the Paxils, the SSRIs, the serotonin releasing inhibitors, the SNRIs, the Wellbutrins, and they put her on an atypical antipsychotic, Seroquel. And it's the first time this young woman found any relief. And, you know, my heart just breaks, because that was about an 8-year course. And during the whole time, that theme of, I'm resistant, nothing can help me. I'm treatment resistant, nothing can help me. And, you know, we just stuck in there and said, let's keep researching, let's keep trying. But the thing that was interesting as a therapist, and certainly I want, you know, our listeners to know, is that when we have comorbid diagnoses, when we have multiple diagnoses, that symptom presentation actually can change over time, requiring the medication to change over time. So I wonder, Paul, if you can speak to that, you know, Prozac might be working at one point in time only to find that it's ineffective for the mania, you know, symptoms that present.
Exactly. That's a wonderful question. And if she would have had a really, really, really good psychiatrist, she could have been feeling pretty good almost all that time that she didn't. For one thing, most people who when bipolar is inherited, okay, it's genetic. You can't cause anybody to have bipolar. You can do something that would make it show up a little sooner, and a stimulant like ADD medicine could make it show up a little sooner, or make it more likely in somebody that has bipolar. Yeah, and an antidepressants, you know, like Prozac and Zoloft and Lexapro and Cymbalta and Pristiq, they work great. But if somebody has bipolar but it hasn't shown up yet, it can make it show up, and where they'll get. Let me explain really quick what bipolar is for those who don't know. Bipolar means you have about the average bipolar, because there's a wide variety, but the average would be when it shows up, like I said, it's inherited, and it can show up in your 20s, 30s, 40s, but usually in the teens, 20s, or 30s. But when it shows up, you have about 3 days where all of a sudden you're sleeping, you know, 2 or 3 hours a night, or even not at all. But instead of being wiped out and tired, you have twice as much energy, and you talk faster, and you dominate the conversation, and most people feel real happy and grandiose. They get arrogant, and they get irritable at people that don't agree with them, because they know everything, and they go from project to project, and they flirt more. People that would never have extramarital sex may have extramarital sex, and they spend more money and do things like that for about 3 days. and then they crash and get real depressed and sleep too much, and get depressed for about 6 days. So that's the average, is however many days you're high, about twice as many you're low. And then they're back to normal again for the next 3 months. And then 3 months later, they're up 3 days, down 6 days, 3 months normal. And it can be every 6 weeks, it can be every 3 months, it can be once a year. So that's bipolar. Now, people that inherit bipolar, the majority of them also have ADHD. And so they're kissing cousins, we call them. And we don't know exactly why, but we just know that they do. Now, most people who have ADD don't have bipolar, but out of like about 5% of the population has some sort of bipolar mood, in the range of bipolar from really mild to really severe. And out of the people that about 10 to 15% of the population has ADD. But among people that have bipolar, people that have ADD, instead of having 5% that become bipolar, it might be 10%. So most of them still don't get bipolar, but they could. So in this lady, she had ADD, and so getting on a stimulant, if the ADD is severe enough, if it's real mild, there's even foods. I wrote a book called Blue Genes, Genes, and I've got a chapter 10 in there that talks about foods that you can eat that build up serotonin, norepinephrine, dopamine, and those brain chemicals. And I have some patients with mild ADHD where they can take those, there's some vitamins, To Your Health liquid vitamins that have those things in them, but they could just do it by foods, and they wouldn't need to see me, and the ADD would be sufficient. But if they need a medication, we give them a medication. And then this lady, let's say I was her psychiatrist, so I'd give her a stimulant. If all she had was ADD, I'd give her a stimulant if it was severe enough, and find one that works for her. And then if she started getting, a year later, she started getting more anxiety and social phobia, I would wonder if it were issues that she needed to work on in therapy. So, of course, I'd refer her to a therapist.
We noticed that hormonally, as she entered puberty, the ADHD medication combined with puberty presented, a lot of anxiety. Well, it looked like mania. Yeah.
Okay. Yeah, I didn't know. Yeah, that she was that age. And so if it could just be entering puberty, and it could be seeing her OB-GYN and getting on some hormonal medications might have taken care of it. But therapy, would be important. If somebody's born with social anxiety, some people have 6 kids and all of them are real extroverts, except one will be shy from birth, and they're real shy, and they don't join any clubs, and they don't date, and all that. And I can get a patient like that. And I had one that was like that was so severe. He owned a company, and I don't want to give it away because he lives not too far from here, but he owned a company, and he was successful, and he made it through college somehow. And the only way he got married was somebody proposed to him. But he couldn't even go out and mingle with customers. He couldn't mingle with his people that work for him. He just stayed back in his back room. He couldn't go to his kids' soccer games or anything. And he heard me talking about this on the radio, and he came to see me, and I gave him a fairly high dose of Neurontin, and 4 days later he was normal. 4 days later he was going to his kids' soccer games. He was mingling with his customers and doing all that thing, and he practically kissed my feet. But it wasn't me; it was the medication. But so if somebody has social anxiety, we can get them over that for sure within a month on medication. If they have generalized anxiety disorder, for sure we can get them over it within a month on medication. And anyone that can't get them over it within 2 months, there's something wrong, because there's a wide variety of medicines that work almost 100% of the time. Like Lamictal works almost 100% of the time, but it takes a month to have a full effect. There's other medications that work immediately and never have side effects. And then since she inherited bipolar, there's a certain age where it showed up, and it probably would have shown up anyway. But if she took an antidepressant because of the anxiety or sadness or social anxiety or something like that, that could make the symptoms show up. So if somebody takes an antidepressant and they get those manic symptoms where they're sleeping less, twice as much energy, talking fast, impulse will go from project to project, then they probably have some bipolar genes, and they may be destined to develop bipolar in the future, and they might not get it in the future. But for sure, the psychiatrist should put them on a mood stabilizer like Lamictal. It's safe and works almost 100% of the time and helps anxiety. It gets rid of anxiety within a month. There's no anxiety of any significance. There's no social anxiety. There's no panic attacks. In fact, they use it to treat headaches. It reduces pain. They use it to treat seizures. So we use it for a lot of different things.
Hi, this is Dr. Paul Meier, founder of the national chain of Meier Clinics. I've often told you about how people just like you are getting the healing that they need from emotional issues like depression, anxiety, anger problems, and relational problems. We wanted to share with you Mickey's experience at our day program and how it has affected his life.
The Meier Clinics has been a real blessing to me. Dr. Meier told me that people get well here, and my life has been completely changed. I have been symptom-free for 3 years, and I'd recommend it to anybody that really wants to overcome an emotional problem of any kind.
Mickey's story is like so many others that we receive. It's an encouragement to us, and we hope it will also be an encouragement to you to call us to get the emotional help that you've needed. Please call toll-free 888-7-CLINIC to be connected to the Meier Clinic program nearest you. That's 1-888-7-CLINIC, or go to meierclinics.com. That's www.meierclinics.com.
So that's what I would have done. When she developed the bipolar symptoms, I would have started her on that and maybe not given her an antidepressant until she got normal. And then when she gets normal, if she still has dips, then you can add an antidepressant and it'll work great if they're on a mood stabilizer.
I don't know if what you would do in this kind of situation, because with this particular person, and I call it a bit of a smorgasbord, if you will, of diagnoses. She certainly has, a couple of, definitely ADHD, definitely anxiety, and definitely bipolar disorder. And in her journey, she's really had to decide which symptoms are the most disturbing to medicate, because with a stimulant, the stimulants, though she was able to focus and perform work, school, those kinds of things, the side effect of the agitation and anger, which was her main presenting symptom of bipolar, was just exacerbated. But when she went to the atypical antipsychotic, her racing thoughts, and she was able to sleep and she was able to calm. But for her, it really was a trade-off. Am I going to perform at an A level or get, all these promotions at work, or am I going to be good enough, because the bipolar symptoms are far more disabling. So, with the treatment resistance, what I try to tell folks is that, there are, when you have 3 diagnoses and you have 3 different, presentations of symptoms, I haven't seen a miracle drug that's going to get all of those. Any thoughts on that of, prioritizing or triaging symptoms?
Yeah, I think you have to prioritize them, but I think you can take medication for all 3. I've got 100 patients probably that are taking bipolar medicine and anxiety medicine and ADD stimulants all at the same time, and they've been seeing me for 20 years, and we haven't had to change their meds, and they're doing great. But do
you find the stimulants
the bipolar is the primary one that you need to treat, and that's either used by treated by a GABA medication like Lamictal or an atypical antipsychotic. They work great too, like Seroquel or Abilify, or there's a lot of them that you could use, and Latuda. Latuda helps bipolar and the depression, so you wouldn't need a separate antidepressant with that one. But so I would make the bipolar the priority, because you don't want them to get manic and blow their life savings or something. But any of the medicines that help bipolar get rid of anxiety. So whether it's an atypical like Seroquel or whether it's Lamictal, once they're on either of those for a few weeks or a month, the anxiety's gone, the social phobia's gone. You don't need to worry about it. But the ADD, the stimulant, can make bipolar worse. But if you're on a mood stabilizer on the right dose, the ADD medicines won't hurt it at all. Now, if they got a real high dose of an ADD medicine and the mood stabilizer wasn't quite high enough, then they could have a manic episode from it. But if you have the right meds, if you use the right meds, you can treat all 3, and you just have to prioritize which ones you use first.
Lisa, go ahead. You had a question in there.
Sure. And this might not be a fair question, but it's certainly one that I find myself curious about. So, there are so many different medications. And again, when I'm keeping in mind treatment resistance and, when someone goes to their general practitioner, And I find that with general practitioners, they tend to prescribe a limited amount that perhaps they're comfortable with, and then we'll refer out for that. But, and so I see kind of a common, with a general practitioner, I see the Prozacs, the Zolofts, maybe Celexa, and occasionally Wellbutrin. But when you go and you meet with someone, Paul, is there any way that you would be able to differentiate whether you're going to start with a serotonin medication or a dopamine such as Wellbutrin medication? In your experience, do they have a different clinical profile, or what do you see there?
Yeah, if they if they have bipolar symptoms, then Wellbutrin is the best antidepressant for bipolar. And when I've written 2 books about bipolar, like the Blue Jeans and also Mood Swings. And for the research, I studied some statistics done by 60 places in the United States that treat bipolar and what they consider the best bipolar medicine, the best antidepressant, and when to use this, when to use that. And the number 1 antidepressant with bipolar is Wellbutrin, even though it doesn't help anxiety at all. It can't trigger a manic episode, and the serotonin ones can. So Wellbutrin's a really good antidepressant, and it gives you more joy, but not through serotonin, through norepinephrine and dopamine. And it gives you more energy, focus, concentration, motivation, and you give that with a mood stabilizer. But if they have bipolar, you could use Wellbutrin right away with the mood stabilizer. But with the other ones, you would give them the mood stabilizer first, and when you get them on enough dose, then they could take a serotonin one or a combination one. And another thing people can get is genetic testing. Now, genetic testing is still expensive. Like, it costs about $4,000, but like, we've got a deal with a company where we can get it for $300 to $700 maximum. That's still a lot of money. Where it would show whether you'd do better on serotonin or SNRI, which is serotonin and norepinephrine. And I don't want to get people too confused, but I can usually tell if a patient doesn't have any bipolar symptoms, but they're real depressed. And first I ask them if you've tried anything else, and did it work great? And if they've tried a couple things that don't work, then that helps me decide. I ask them, do you have any relatives that are on an antidepressant that works great? If they have a brother or a sister, a mom or dad that is taking one that works great, it'll probably work great on them too, because they have similar genes. And if they have a lot of anxiety, then I wouldn't want to give them Wellbutrin as a first choice, because it doesn't help anxiety at all. But with someone with bipolar, it'd be okay, because the bipolar medicine always gets rid of anxiety. And so a lot of it just depends. If they're depressed and they're real sluggish and they don't have any energy, then I'd give them an SNRI that builds up serotonin and norepinephrine. Serotonin gives you love, joy, peace, patience, gentleness, meekness, the fruit of the spirit, and good sleep. And norepinephrine gives you joy from a different chemical, but gives you more motivation, energy, focus, concentration, and improved sexual performance and enjoyment. But it doesn't make you want sex more. I would never give any male anything that made him want it more. Well, there's enough temptations as it is.
It's interesting, Paul, when you talk about the Wellbutrin being, associated with a bipolar. And granted, I don't prescribe. I'm a clinical psychologist, but as a psychiatric nurse, I get to watch and certainly monitor the effects of so many medications. And when I have clients in my office over the 25 years that I've been a therapist, and it makes sense to me now, but one of the commonly masked symptoms, or diagnoses under alcohol abuse and addiction, we know is bipolar, and also ADHD, which is associated with dopamine deficits in the prefrontal lobe. And so it's interesting, because as a clinician, when a client is here and then I'm saying, you look to be, in my opinion, you would likely respond well to an antidepressant, and I would encourage you to follow up with this doctor. One of the things that I look for is substance use, abuse, and dependence in their family history. And it makes sense now that you say that, it's because of the dopamine deficits that are associated with substance use abuse, but then the underlying bipolar. And I find that those people respond really well to Wellbutrin. So I was curious of, how you differentiate that from a psychiatric point of view versus what I'm seeing, in a clinical basis. And it makes sense, it kind of falls together.
Yeah. Yeah. Okay. You've done a lot of studies over the years, haven't you? You're asking.
Well, I'm a bit of a science junkie.
Well, you had a lot of training. You've had a lot of training. I mean, you're a therapist and and all this other training too. But that's a really good question. Now here's something that'll surprise people. There's a lot of, I don't know what percentage of the population are alcoholic. I would guess 10% probably, but there's a lot of people that are alcoholics, and for a lot of different reasons. And most common would be, they have a lot of pain and they're numbing their pain and things like that. But there's a lot of different reasons. But people that have bipolar, even if they don't have any alcoholic traits or tendencies or anything, 70% end up abusing alcohol before they get treatment, because to bring yourself down from a mania, you need a GABA medicine, or like a Lamictal or one of those. I haven't used lithium in 20 years, and lithium works, but it's got a lot of side effects, so I don't recommend it. But Lamictal is the number one recommended one. But anyway, they need a GABA medicine or a dopamine medicine, like atypical. But alcohol is a GABA medication in a way, because if they get manic, they can get drunk and pull themselves down from the mania. And unfortunately, if a woman drinks more than one glass of alcohol of wine a day, or more than 2 beers, it starts depleting serotonin and making them more depressed. And if a man drinks more than 2 glasses of wine a day or 4 beers, it starts causing brain damage and liver damage and depleting serotonin, making them depressed. If you took 100 happy people and made them drink a bottle of wine a night, some of them would commit suicide, and maybe half of them would get clinically depressed, because alcohol is a depressant. If they drank 1 glass of wine a night, they'd probably live longer and be happy. But and so 70% of bipolars become alcoholics just because of their bipolar disorder. And what's cool is when they get on a good bipolar medicine, that's a GABA medicine, like Trileptal or Lamictal, then the alcoholism goes away very easily. It just, when they're taking that to treat their bipolar, it's real easy for them to quit alcohol. And so it's different from normal alcoholism. So does that answer your question, or was there some other?
Oh, absolutely. The question was, the difference between serotonin-based mood disorders and dopamine-based, because another thing that I often see, and I think you probably get a lot of this in your practice as well, is that, on some of the SSRIs, the selective serotonin reuptake inhibitors, especially Zoloft, which is so great for an anxious depression, folks get discouraged because of the significantly negative effect it has on their sex life. And Wellbutrin, I don't see that. From the practical standpoint, I don't get those same complaints.
Yeah.
But it's serotonin.
Right. In fact, yeah. Okay, go ahead.
Well, it was encouraging for me to hear you say that the SNRIs don't have that same effect. I mean, perhaps Effexor would be a better choice than Zoloft. Yeah. Well, they can.
The SNRIs, they can. The SNRIs can have sexual side effects too. Any serotonin medicine can. Usually, like even Zoloft, it might be 10%. With Cymbalta, which is SNRI, it might be 2%. There's a couple of them, newer ones that don't ever cause sexual side effects. Let's see, I've got it right here on my computer, like Fetzima and Trintellix. There are 2 new ones that almost never ever have sexual side effects. If an antidepressant has sexual side effects, then I tell people, even though a lot of them say, well, I feel great, I don't want to get off it because I feel great, I'd rather live without sex. And I said, well, you're only 35 years old and you're married, and you shouldn't do that. So I would add Wellbutrin to the medicine that's causing sexual side effects, and usually that'll correct it, so the sexual side effects go away. And if it doesn't, I'll switch them. I'll leave them on the Wellbutrin so they won't get depressed, but I'll gradually go down on whatever serotonin medicine is causing it, even though it's working great for their depression, and gradually go up on another one that's likely to work, and switch them to one that won't cause sexual side effects.
What I'm wondering, Paul, is if there is a particular medication where you would start with one who struggles with PTSD. Are there medications that stand out over another that's more effective?
Well, PTSD, for our listening family that may not understand, that's post-traumatic stress disorder, like soldiers that go off to war and they see their buddies get their heads shot off or have been wounded and stuff. I've visited soldiers on a psychiatry ward where they were suffering from PTSD. And I've had a lot of patients, probably several thousand patients in the last 42 years who were either sexually abused or they were in a car wreck and they saw somebody die or different things. And as a result, they jump if they hear a sound. They're sensitive to light sometimes. They have panic attacks. They have flashbacks where the event keeps flashing into their head, and even though they don't want it to, they have nightmares about it at night. So they can have all those PTSD symptoms. And so, of course, the main thing that they need is therapy. We've got a day program. We've got 3 of them, one in Seattle and one in Dallas and one in Chicago. And I evaluate everybody that comes to the one in Dallas for an hour to figure out what's going on, and then I supervise. But if somebody has PTSD, we'll bring them in and do 7 hours a day of therapy for 3 or 4 weeks, and we can make them a lot better from the therapy. And we'll do Gestalt techniques, we call it, where, if somebody got raped, we'll put an empty chair in front of them and pretend like the rapist is sitting there and have them talk to the rapist and tell them how they feel. And at first they'll be resistant, but then after a few minutes, the tears just come flowing out and they have decathexis. And one session like that is better than 6 sessions talking about it. And we can see them get a lot better in 3 or 4 weeks, and not necessarily over it. They may need outpatient therapy for another, 9 months or a year or something. And then we also use medications. We can, like a lot of people are resistant to benzodiazepines, and I think they're great for short-term use, like a clonazepam or Xanax. I could give them Xanax time release, for example. It's a 24-hour Xanax, and not a high dose even. I could give them a couple of 0.5 milligram tablets and tell them to try one a night, and if that doesn't work, take one twice a day. And usually, the first night they take it, most of their symptoms are gone, and they can work on it in therapy. The guy that runs Dr. Coburn has been on with us before with Kristen, and he runs our day program, and he always tells me, now, Dr. Meier, don't make them so relaxed right off the bat that they don't work on their problem. Because I can make somebody totally relaxed like 20 minutes after they get here.
Everything's good, yeah.
But we need to do the healing and growth component.
Exactly.
Yeah. But I can give them either a major tranquilizer or a benzodiazepine temporarily. Lamictal is my favorite medicine for almost everything, but it takes about a month. And an antidepressant would be helpful because they're usually, depression is anger turned inward, and if somebody abused you, of course you're angry. And then a lot of people that get abused blame themselves, especially if they're abused as children, so they have false guilt. And so we deal with those in therapy and Gestalt techniques and different techniques. But in the meantime, I can put them on an antidepressant that'll make them feel 25% less depressed per week. And I don't believe in just using medication for PTSD because they have issues that need to be resolved. But I can make their symptoms go away from PTSD very quickly.
I love that idea of the 24-hour Xanax, the 0.5 milligrams, because what I find, with significant trauma, such as, a sexual assault or multiple sexual assaults, sometimes when I'm trying to work a parallel process of grieving and forgiving, trying to do the deeper work of the healing, going through that process, it's a thin line between how much of that is actually re-traumatizing, meaning they're not able to get through talking about some of the assaults or what's going on because they have panic attacks. And so something like a 2 hours would be a godsend, to help those people, with the healing process. Yeah.
In fact, Lisa, I would probably also give them some 0.5 milligram Xanax or clonazepam that they just carry in their purse, and they don't take it every day. So they might take the 24-hour one temporarily while they're in therapy, but if they ever feel a panic attack coming on, they can take one of those, and it'll make it go away in about 6 minutes, and it'll make it stay away for 8 hours. And with clonazepam, with either of them, you can do this, but if it comes on quickly, they can chew it and swallow it, and it'll work in 2 minutes. And so I would tell them to do that just so they don't have any panic attacks, and so that can help a lot. But then,
therapeutically, therapeutic.
Yeah.
That's huge for PTSD because a sense of control, so if they're running with a 6 out of 10 or an 8 out of 10 with anxiety, and they're terrified of going into a panic, just having that in their pocket, know that if that occurs, I have control, which is unlike their abuse or their trauma that we're trying to deal with. Just having that on them is going to give them a therapeutic sense of being able to intervene with their emotional response to what's going on. So I can see how that would be very beneficial.
Yeah. Okay. And another thing you said is real important for people to know, that if somebody's got a lot of trauma and a lot of buried conflicts, and 80% of our thoughts, feelings, and motives are unconscious, out of our awareness, and that's not just Freudian thought. The Bible says that too. It says in Hebrews 4, the reason we meditate on Scripture, and because the Scripture is more powerful than a two-edged sword, and able to show you your innermost thoughts. And David prayed in Psalm 139. He said, God, reveal to me my innermost thoughts so I can walk in a way that's pleasing to you. And anxiety, in my opinion, the way I define an anxiety, it's a fear of finding out the truth about your own thoughts, feelings, and motives. And somebody with PTSD may have just tons of rage that they're afraid to look at, or false guilt, or fear of intimacy then, and things. And when you're digging them up, if any of us saw the whole truth about what's inside of us at once, some of us would just fall on our knees and say, amazing grace, how sweet the sound that saved a wretch like me. And some would find out that they're a lot better than they think they are, and some would go psychotic. Some could become actually psychotic because they're seeing too much too quick. And in therapy, lots of times they may get a little worse before they get better. And we find that in the day program too, where we're digging stuff out. We're trying to dig it all out in 3 weeks. And so we may need to give them even a major tranquilizer if they're doing intensive therapy, so they don't become psychotic or a whole lot worse while they're getting the therapy. And just a funny thing that I used to have, people listening to us today, I'm 73, so most of you in our listening family right now don't even know what a Ringer wash machine is. But when I grew up, we didn't have wash machines. And
did
my
you
mom
pull the
would.
chain?
I don't know what that is.
Did you pull the chain, Paul, too? I mean, is that what we're talking about here?
Did it have a washboard
My mom would
attached to
wash
it, Paul?
Yeah, my mom would wash the clothes, and then she'd put it in a wringer where there's two round things that squeeze the water out of it, and she'd wind it round and round with her hand until all the water came out of it. Then she'd go hang the clothes out on a clothesline until it dried. Okay, and so I used to have a poster where a person who had been through severe trauma and had like PTSD and was getting therapy and stuff. It was going through that Ringer wash machine herself, and half of her body was through it and half of it wasn't yet, and she had this panicked look on her face. And the caption on the poster was, "If the truth sets you free, you'll be free indeed." Because there's a verse in the Bible that says that if the truth sets you free, you'll be free indeed. But the caption on the bottom said, "But first it'll make you miserable." So when you're gaining a lot of insight, you may feel worse before you feel better, because it's hard to look at some of those painful things. But when you cry about them and deal with them and get rid of them and forgive, it doesn't mean condone or put up with it. You have to have boundaries and all that. But when you work through it, there's such relief, because the symptoms go away, the anxiety goes away. You can treat almost anybody with panic attacks and anxiety without medication. You can treat them with just therapy, almost anybody, but unless it's inherited. But they might be so miserable that they, can't go to work and things like that. And so we would encourage them to get the therapy to get over the problems, the things that they're afraid to look at, and they're unconscious. But we'd give them enough medicine so they can function and go to work and things like that while they're working through it. Then when they finish working through it, the meds that used to make them relax start making them tired now, because they don't need it anymore. And we wean them off it and say, okay, you don't need it now.
Paul, I have another question for you. And this is, you've given such fruitful insight, with regard to issues with the treatment disorder and where people run into trouble. And I know one of the components that I see, again, as a therapist working intimately long-term with clients, is not a right fit with their psychiatrist or their prescribing doctor. I wonder, if you can address, or if you could speak to how one goes about finding that good fit, or how does one go about finding an excellent psychiatrist such as yourself that's going to be able to see it globally like this? Meaning, people ask me all the time, who do I work with? And in our small town, we have one psychiatrist, so we don't have a whole lot of choice there. But in general, in the bigger cities. How might one go about, finding the good fit, the right psychiatrist to work with?
Yeah, excellent question. And it's amazing to me. I mean, it's amazing how you have to be really pretty smart to become a doctor and pass the national board. It's on every field of medicine. So even doctors from other countries who come here and get licensed are really, really smart. But smart doesn't mean common sense, and some psychiatrists are really, I mean, I get patients that have seen a psychiatrist for 10 years and he had them on 10 milligrams of Zoloft the whole time, and they might be 5% better, but they're still miserable. And when the normal dose is anywhere from 50 to 200, and I can increase the dose and they're well in a few weeks, And so some aren't very good. To find a good one, if you see a counselor, I think you should always find a good Christian counselor. And you can do that either by asking the secretary of the largest really good evangelical church in your area who her pastor recommends to regularly, because that's one of the best ways. Or you can call Focus on the Family, 1-800-A-FAMILY, and they have thousands of referrals. Or you can call our number, 1-888-7-CLINIC for the Meier Clinics, and if we know somebody in your area, we'll refer them. For a psychiatrist, I don't think it matters if what religion they are. I mean, if you find a really good Christian one, that's nice because you'll relate to them better, and things like that. But it doesn't matter what their religion is. And I would get a referral from your family doctor. I'd say, who do you refer people to that's really, really good? And because there's usually a reason why an internist or a family doctor keeps referring his patients to a certain psychiatrist, because it's the one that'll have the best results. So I would get a referral from another doctor, or if there's a pastor of like here in Dallas, there's about 3 churches that have 20,000 members, that are Baptist or Bible churches or things, and you could ask the pastor secretary, who does he send people to for psychiatry, and do they get really good results, and that'd be another way. The guy that I think is best at meds here in Dallas, in the D magazine, stuff like that, I'm rated 3rd, but there's a couple of psychiatrists that really are better than me, and like I said, there's this Jewish doctor that's just brilliant. He can visualize the D2 receptors and A1 receptors, and this one will interact with this and this and this, and this combination will work, and he almost always figures it out. And he's a nice guy, but he's not real, he's not warm and fuzzy like I'm a real warm and fuzzy guy. So I encourage them to go see him. They'll go see him. They'll get him on the right meds, and lots of times they'll come back to see me, and I'll keep him on his. Because I'll get a hug.
So someone you trust and someone who comes highly recommended from other professionals in the area or people that you trust within your community. Yeah, it comes to me often, and I tell my clients that it's important that you feel heard, by your doc. It's important that you feel understood. It's important that that your symptoms aren't minimized. I had a client come in once, and she said, I'm having panic attack secondary to PTSD when I lay in bed next to my significant other. And the response from the psychiatrist was, then don't lay in bed next to your significant other. And my heart breaks for that, that no, we can help you with that. We can help you heal that PTSD. And it was shocking to me. And so, often that question comes to me. Find that,
stupid. Yeah, he's just plain stupid. He's an idiot.
People love Paul because he'll just
he's just plain stupid. His diagnosis, that psychiatrist's diagnosis is stupid. Because you can, like I said, I could give that same gal some medications without over medicating her that would make her symptoms minimal, or for sure guarantee she wouldn't have any more panic attacks, and she could continue in therapy, and she'd make her progress in therapy,
Well, if we come back to the reality of the numbers, that we have, 1 in 5, folks suffer with mental illness, and 150 million people worldwide. That's a lot of people suffering, and it's heartbreaking to think that only 50%
I think it's a lot higher than that.
Yeah,
I think it's a lot higher than that.
That's where just
I think 50%. I think 50%. I think 50% of the population get depressed sometime in their life, even though most don't get treated for it. So I think it's a lot higher than that.
And so if we think about the amount of people who are struggling with even the severe, depression or the severe debilitating anxiety, not leaving their homes to even go to a doctor's office, and then the discouragement that they get with not getting the proper treatment, I'm super passionate about, finding the right fit, with both a clinician and a prescribing doc, realizing that,
Yep.
like you said at the beginning, that it's like a thyroid disorder or insulin, that there's neurochemical imbalance. And if we can address that imbalance, you can function well and healthy and prosper, but that it takes some time. I mean, I tell my clients that we don't have a blood test that says, well, the genetic testing is helping. The cheek swabs are certainly helping and becoming more popular. But unfortunately, we don't have a blood test that says, your blood sugar is at X amount and you need some insulin. We don't say your SR, you need an Effexor over say a Ritalin, or excuse me, over a Prozac. But I try to tell folks that we're embarking upon a journey to find the right fit, is what I tell them. And the other thing that I tell them,
and we're getting close.
Well, we are getting so close. And the other thing that I find is so very effective with my clients who are resistant to go on an antidepressant or on an anti-anxiety, I say, let's just remember that this is a trial. We're going on a trial. Let's give it 30 days. And if in these 30 days it can improve our functioning and our mood and our joy, then we've learned something. And if not, then we can continue on the journey, because so many people still are, oh no, I don't want to do that. That means I'm messed up or I'm not okay. And I say, give me 30 days, give me 2 weeks, because for a lot of folks, as you know, you can significant improvement in a week to 2 weeks.
No, here's something important for people here. Like, with the anxiety medicines, that, they work 100% of the time. Almost all of them work 100% of the time. But with the antidepressants, they work about 3 out of 4 times if a psychiatrist gives it. If the family doctor gives it, he gives too low a dose and it won't work. Or he may give the wrong one and it doesn't work. And so that's why there's a lot of people that take antidepressants that don't seem to get better. But if they get treated by a good psychiatrist, there's still going to be 1 out of 4. So when I see a new patient that's real depressed, I put them on the best antidepressant I can think of for them. And 3 out of 4 times, they're going to come back in a month and say, this is the best I ever felt. And 1 out of 4 times, they'll come back and say, I don't feel any better at all. And I explain that the first time I see them, that might happen that way. And so I give them another antidepressant. And just because the first one didn't work doesn't mean the second one won't work. But if you've had statistics, then so they might try 2 in a row that don't work. They might try 4 in a row that don't work. But the chances that like 7 in a row won't work are, you have to multiply 4 times itself 7 times. So it's 1 chance in 4 times 4 times 4 times 4 times 4 times 4. And it's like, there's 1 chance in about 20 or 30,000 that 7 in a row won't work. And so, but in the meantime, they're depressed but I can give them other medicines that make it, at least they're not having anxiety and things, but they may be depressed for 7 months if they have really, really, really bad luck. And then one other thing is, people worry about side effects. And when you see these ads on TV, well, they say, this medicine's really good, but you may develop liver cancer, you may develop this, you may develop that. When I listen to that, I laugh and I think, when I listen to those ads, I laugh and I think, I've been giving patients those medicines for 42 years and never had any of those side effects in any of my patients, but they have to list anything that's ever going wrong. And I could put an ad on there on TV and say, if you drink bottled water, 1/3 of you will get cancer, 10% will have heart disease, 100% of you will die eventually. And you could go on, and those statistics would be true, because that's true for everybody, whether they drink bottled water or not. And so, they say if a teenager takes an antidepressant, it may cause suicide. Well, if you had 100,000 teenagers that were suicidally depressed and they didn't take any antidepressant, then, maybe 10% of them would die of suicide, or maybe higher, maybe 15% would. And if they all took an antidepressant, then maybe 3% still would, and the rest wouldn't. And so, some people are going to commit suicide no matter whether you give them an antidepressant or not. Even if they feel better, they're going to, for different reasons, they might. Mm-hmm. And then there's a few people that have underlying schizophrenia or bipolar, where they actually could. So in some rare circumstances, they could get worse from an antidepressant. But in most cases, that's an exaggeration. There's parents that are afraid to let their teenager take an antidepressant. But if my teenager was clinically depressed, man, it's something like 1 out of 33 or 35 teenagers will attempt suicide in the next 12 months. Mm-hmm. It's really high. It's 300% higher now than it was 50 years ago.
Absolutely. Well, you know what I think after listening to the two of you? You don't need me to moderate you.
Oh, Kristen, I forgot you were there.
All right, so Dr. Paul Meier and Dr. Lisa Day, there is so much to talk about on this topic. There's no way we would be able to cover it in one show. So we are going to continue this conversation, because there are things I want to know too. There are people in my life that, I wonder why isn't therapy working? Why hasn't it worked? And the two of you together, are just on fire. You answered a lot of questions for me that I didn't even need to ask. So I know our listening family is going to feel the same way. And we will come on again and we will continue this conversation. But for today,
it doesn't even have to be a medication thing.
Right.
I used to do therapy for years, and I trained at Duke. And at Duke, we had 2 professors for every student. That was the student-teacher ratio, was 2 profs per student. And when I'd see somebody for therapy, there'd be 2 profs watching through a 2-way mirror, and from 2 different schools. One would be psychoanalytic, and one would be Gestalt or some other cognitive or whatever. And so then they would critique me after I was over. Then they might argue with each other over what might be best, but you learn. I learned a lot of different techniques and stuff. It doesn't mean I'm that good, but I've got a lot of experience doing therapy too. So we could even discuss therapeutic issues and just
that sounds good.
Different things.
Well, what's interesting for me.
Anytime you want me, Lisa, you do a great job. And I think I told you already. My wife and I went to a movie that was like a 40-minute drive away. And so when we got in the car and we heard about all these changes, getting on smart TV and all that stuff, my wife pulled out her iPhone and said, "I'm going to just try it out." And so while I was starting to drive home, she said, "I want to hear a podcast on Clinical Christian by Lisa Day." And it came right on immediately. And so we were able to listen to you on the way home. You were fantastic.
Well, I appreciate that. If you listen to the one on forgiveness, I talk really fast. I need to slow down, but I appreciate that. And you know what? I love it. And I just ask that thy will be done, his word be spoken, because I feel like that I love to teach. And when people are in my office, they're like, where can we get this material? And it's an eclectic collection, right? We don't reinvent the wheel, but I certainly do enjoy it. And I'm certainly open to feedback. That's what I want. Feedback.
So as a listener of multiple podcasts and as someone that produces many shows about mental health, here's what I, Kristen Walker, enjoy so much about listening to the two of you that makes a huge difference for people that have struggled with what they feel like is treatment resistance or what actually is treatment resistance, okay, is that they don't get a feeling that this person that they're going to for treatment is really connected to them, really understands or is passionate about what they do. And the two of you are so passionate about what you do. It shines through in what you say and how much you study before we do these shows, how much you want to answer, and that we may go over on shows and we have to edit things and so on. So I want our listening family to understand that you're listening to two people that care so much about what they're doing. We hope you enjoyed this podcast. Tune in next time for another engaging discussion on relevant mental health topics. If you have any questions about Meier Clinics, please visit our website at meierclinics.com. That's MEIER clinics.com, or call us at 888-7-CLINIC. Don't forget to leave us a review on iTunes, Stitcher, or any of your favorite podcast apps. And please note that we are a member of and produced by Mental Health News Radio Network, MHNRnetwork.com.